Good afternoon, everybody. I'd like to welcome you to our next session of the APDR National Virtual Noon Conference. My name is Dr. Harp Beatty. I'm the chair of the APDR Education Committee and the Neuroradiology Fellowship Director at Boston Medical Center. I'd like to welcome you all to our session today on thoracic imaging. Just a few housekeeping items as we do every session. As a reminder, the webinar is being recorded and all questions and comments are being recorded as well. Secondly, as a webinar attendee, as you can see, your microphone will be muted to ensure optimal quality for all participants. And if you do have questions for the presenters, please use the question and answer tool in the Zoom platform, and we'll try to get to those questions as best we can. I'd like to welcome two amazing radiologists and educators to our session this afternoon. Our first speaker will be Dr. Javad Azadi, Assistant Professor of Radiology at Johns Hopkins. He'll be speaking on COVID preparedness, RSNA task force recommendations. And we're lucky to have our second speaker today, Dr. Ritu Gill from Beth Israel Deaconess, Associate Professor of Radiology at Harvard Medical School. And her topic will be lung cancer, diagnosis, and management. So without further ado, I'd like to ask Dr. Azadi if he'd be willing to share his presentation with the group.
Hello, everyone, and thanks for joining us. I would like to review COVID-19 preparedness. These are the guidelines developed by the RSNA task force over the last several weeks. Hopefully, most of you have implemented most of these, but if there are guidelines that you haven't implemented, I encourage you to bring them up to your faculty, to your managers, to try to make sure that you're doing the best for yourself and for your patients. I have no conflicts of interest to disclose. So who is the RSNA COVID-19 task force? It's a group of radiologists and radiology scientists across the country and the world. We meet weekly. We discuss the upcoming literature as well as give guidance to radiologists and their questions. So the objectives for this talk are three. The first is to review mitigation strategies to decrease healthcare worker COVID-19 infections, review strategies to conserve and preserve PPE, and to review strategies to maintain a sense of normalcy in these otherwise completely abnormal times. So if you take one thing away from this talk, it's an ounce of prevention is worth a pound of cure. Make sure you're doing proper hand hygiene. That includes washing your hand with soap and water for 20 seconds, if available. If you're in an area without water, hand sanitizer should be used. 60% ethanol or 70% isopropyl alcohol effectively inactivate coronaviruses. Avoid touching your face. And then if you haven't been properly trained in PPE donning and doffing, there are videos available. These were actually developed, I believe, when Ebola was an issue in the mid-2010s, but the ideas are still applicable today. With regard to elective imaging, we recommend postponement of all non-urgent outpatient imaging. And that includes canceling mammography, screening mammography, lung cancer screening, CT colonoscopy, DEXA scans, and coronary artery calcium scoring. Reason being is that it's not worth putting those patients at risk for COVID-19 infections, or if they're asymptomatic, putting the technologists and staff workers at the imaging sites at risk for asymptomatic spread. Other elective diagnostic exams can be postponed, but it's really going to be a discussion among all the shareholders, including the patient, regarding the importance of the exam. Now, it's important to remember that critical and time-sensitive imaging, especially those that are necessary for treatment decision-making, such as when to initiate chemotherapy, should be performed within the needed time frame. For patients who are coming to your imaging sites, they should really only be traveling with visitors who are necessary for the patient to understand or to have adequate mobility. So if the patient can walk and can understand on their own, they should be attending their visits by themselves. The radiology front desk or the hospital outpatient center entrance should be screening these patients for symptoms. If a patient is symptomatic, they should be given a surgical mask, and the patient should be considered a patient under investigation. And the healthcare worker should be employing droplet and contact precautions and isolate the other patients while they await scanner availability for their study. If possible, the patient should be imaged with portable equipment in an isolation room. So for example, if they're getting a chest radiograph. But if a portable imaging modality is not possible after appropriate droplet and contact precautions are instituted, the patient should be imaged using main rooms. With regard to canceling procedures, elective non-emergent procedures should be postponed or canceled during the pandemic surge. The reason why is you want to conserve resources, notably PPE, in your staff, conserve inpatient capacity that may become needed as your hospital may be undergoing a surge, consolidate staff for appropriate mobilization, as well as to protect our patients from unnecessary COVID-19 exposure. Now, this should not affect emergent critical procedures. Remember, your patients still have emergent conditions that are life-threatening that should be treated, and this should not dissuade them from coming to the hospital. Ultimately, decisions to cancel procedures or postpone decisions should be made jointly with the referring healthcare provider, and scheduling of future procedures can be done in coordination with the ordering physician with, placing the procedures into one of three categories: non-urgent, and those are procedures that could be postponed for months; time sensitive, where a short delay is acceptable; or critical, and that needs to be done as soon as possible. For our institution, our fellows were instrumental in calling the providers for elective biopsies and discussing the urgency of these cases with the doctor, and it was actually able to postpone a large number of these procedures while proceeding with the procedures deemed time sensitive and critical. So you have a patient who may have COVID-19. Patient screening can be performed with real-time PCR, and as testing kits become available, this is going to be something that we'll do prior to image guiding procedures, especially procedures that have a risk of aerosolization or any patient who may undergo surgery. If a patient's considered high risk and they have a negative PCR, they should be retested because of the chance of it being a false negative. Chest imaging is currently not used for screening or for follow-up if the real-time PCR is available, with the exception as if the patient surge exceeds the capacity for testing and quick throughput is needed. Imaging should be kept in mind for patients with atypical presentations. Remember, not all patients present with chest symptoms. Some have abdominal pain, some have CNS symptoms. And finally, assess the role of imaging and determine the reporting language from your studies, either patients who are considered PUI or confirmed COVID-19 cases, in consultation with your referrers, so you're using the language that they want to read and that ultimately the patients may end up reading. With regard to screening and evaluating healthcare workers for return to work, we recommend screening all employees and patients at all entrances, and that includes looking for symptoms within the last 72 hours, and as well as any potential SARS-CoV-2 exposures, as well as considering temperature checks if your manpower allows for it. Employees should complete a daily attestation of health and affirm a lack of symptoms, and these symptoms include fever, new dry cough, sore throat, new shortness of breath, new muscle aches, or recently, a loss of taste or smell has come out as a sensitive symptom of COVID-19 infection. Now, just because you have these symptoms or one of your coworkers has these symptoms doesn't mean they have COVID-19, but if you do have these symptoms, you should stay home and contact your occupational or employee health officer for the need for potential further testing. Per CDC guidelines, there are two options for returning to work for healthcare workers who unfortunately would have tested positive with COVID-19. The test-based strategy, if you have 2 negative PCR tests separated by at least 24 hours and resolution of symptoms, you can return to work. For a non-test-based strategy, this requires you to stay at home for 7 days from symptom onset and at least 72 hours after symptom resolution. That includes fever and respiratory symptoms. After you return to work, you should wear a face mask at all times while in the healthcare facility or until all symptoms are completely resolved, or 14 days, whichever is longer. Now, I'm sure many of you and your co-residents have started wearing masks, and that's an alternative to only wearing it for 4 days. You read it, you could wear your mask indefinitely. You should restrict patients who've had COVID-19 from contact with severely immunocompromised patients for at least 14 days to eliminate the chance of asymptomatic spread. Another approach the CDC proposed is having COVID-affected healthcare workers continue to wear a mask for 7 days after symptom resolution. But again, I think this is less important now that most of us are wearing masks in our day-to-day practice. With regard to PPE, All PPE guidelines should be determined based on your institutional guidelines with resource availability and conservation strategies all taken into consideration. Staff who use PPE should be educated through communications and guidelines and should have easy to read charts. The CDC actually provides very easy to read charts, such as the one on the right, for appropriate donning and doffing PPE equipment while avoiding self-contamination. As I mentioned before, surgical masks should be worn by all healthcare workers while in clinical facilities, whether or not providing direct clinical care, but that is with consideration for institutional availability, as well as institutional and local and federal governmental guidelines. So if you don't have masks, then the expectation is different than if you have a surplus of masks available. If your mask is soiled or it is exposed during a droplet precautions episode without a covering face shield, that mask should be considered contaminated and it should be discarded, and you should get a new mask for the next patient encounter. However, if you're just walking through the hallways, your mask is considered still clean. If you have face shields, you should wear them over your face masks, especially for patients with respiratory symptoms. And you really want to be judicious with conservation of your PPE. So if you don't need to get a new mask or a new face shield, you shouldn't. One strategy that we use at Hopkins is we actually wipe down the face shields between patients to preserve face shield PPE. If you can, develop a method to identify patients as either under investigation or COVID-19 positive and have it reported in the EMR. Remember, many patients are tested outside of your healthcare system, and if the information is available either through an information exchange or through reporting by their primary provider, it should be easily imported into your EMR, and so that all workers working with these patients can be aware of their status. If you do have staff who are in direct contact with COVID-19 patients or patients under investigation, if they haven't already been fit tested, they should be fit tested for N95 masks, or if your fit testing has expired. Now, the image on the right shows a gentleman being fit tested with a Drago respirator, which can be used at Hopkins as an alternative for N95 masks, but the procedure is the same. They put a mask on you, they spray a sweet-smelling solution, and you shouldn't be able to smell it through your mask. If you do, it indicates that you don't have an adequate seal. Now, for residents and fellows who might have beards, recommend shaving their facial hair for appropriate N95 mask fitting. If you can't achieve a suitable seal, then the mask isn't effective. N95 masks should be preserved for reuse, so you can wear overlying surgical masks over the masks, or if you have a face shield available, or if you have central cleaning policies available, such as using UV light or whatever is available at your institution. Some things to be aware of that I wasn't aware of before making these guidelines. Some N95 masks have a metal strip, and they're not necessarily safe to go into the MRI room because you'll lose your seal. There are MRI safe N95 masks available. And finally, a PPE conservation strategy, which makes a lot of sense, is minimize the staff in the room with COVID-19 patients and PUIs to those only needed to perform the procedure. Because the fewer patients, or rather the fewer staff members going in, the less PPE you need to use. The CDC actually has nice guidance for which facial hairstyles are suitable for PPE. And as you can see, you can wear a soul patch, you can have side whiskers, you can have a Zappa, painter's brush. The villain might not cut it, but essentially, if the hair extends beyond the seal of the mask, it won't work. In terms of the radiological imaging of COVID-19 patients, you really want to assess the need of the imaging. You really should not be imaging as a screening or evaluation of COVID-19. You want to limit the patient travel. If you can perform the imaging at the patient's bedside, you should. You don't want to send these patients to high volume imaging centers, which most of the high volume imaging centers are probably low volume now. But ultimately, you want to consider whether the imaging will impact the patient management. So the different precautions that are in use right now is the droplet or contact precautions with eye protection. That's going to be the majority of cases. These would be patients under investigation. These would be patients with respiratory symptoms, or depending on your institution, this may be what you employ for all patients. But patients will wear surgical masks. The healthcare workers will wear either N95, PAPR, or a surgical mask, as well as a face shield and appropriate contact precaution gear, and use appropriate hand hygiene. For airborne or contact precautions, these would be the patients who are COVID positive. Any aerosolized generating procedure should be considered airborne. So this is actually a lot more than what I would have thought, but this includes lung biopsy, thoracentesis, enterotube placement, intubation, extubation, anything with tracheostomy or moderate general anesthesia. So in most IR procedures, you'll need to be considering airborne precautions. Patients, again, will wear surgical masks. Healthcare workers this time should wear N95 or PAPR, not just a surgical mask, and contact precautions should be used. Given the limited supply of PAPR hoods, N95s are preferable, but if you have ample supply of PAPR hoods and the filtration units, those are easier to use in my experience. One thing to be aware of is the PAPR hoods cannot be used in MRI suites. So in that case, you will have to use an MRI compatible N95 mask. For cleaning the room following a COVID patient, it's a multifactorial process, and you really need to consider how much air exchange occurs in an hour. You want to defer to your experts for devising a policy for this. So really your local infection control experts are going to be the key person to approve your policies as well as give you further guidance. But the higher the air exchange rate per hour in your room is, the shorter duration needed for room closure. For droplet contact precaution patients, these patients, or the room can be cleaned with standard antiseptic wipe down of equipment using either ammonium or alcohol wipes or any other EPA approved disinfectants. And there generally is no need for room closure if there's adequate air circulation. For airborne patients, you're going to again do a standard wipe down. The room will be closed for 1 hour after the imaging procedure if you have at least 6 air exchanges per hour, and that also includes the cleaning time. So COVID-19 patients or image do shut the room down for a while. If you can, use a HEPA filter, but just be mindful that HEPA filtration is not compatible with MRI suites. Now, I could give a whole talk on the appropriate imaging, chest imaging in patients with COVID-19, but instead I would defer to you guys to read the Fleischner Society guidelines for imaging and patient management during the COVID-19 pandemic. This just came out, I think 2 weeks ago. Worth a read, and it's worth being knowledgeable about the points inside. But what about non-chest imaging? Basically, non-screening imaging is reserved for those in which there will be an impact on patient management. So if there's an alternative diagnosis being considered, or there's acute worsening to an alternative diagnosis, such as pulmonary embolism, especially as it's becoming known that these patients are increasingly coagulopathic and seem to be more prone to developing BVTs and PEs. If the patient requires emergent imaging for any other reasons, appendicitis, cholecystitis, or stroke, that imaging should be performed, and there should be no hesitation to perform it. However, non-emergent imaging for inpatients that can be delayed until either the diagnosis is confirmed or the patient has recovered from the COVID illness and they're no longer considered contagious, those delays should be implemented. And then finally, if your COVID census is high enough and you have the capacity imaging-wise to do this, it might be worth identifying imaging units and scanners that could be used for either PUI patients or COVID positive patients who are undergoing imaging. When it's possible, do chest radiography for your inpatients in their room. The x-ray can actually be performed with the machine outside of the room, with the x-ray tube pointing through the glass and the cassette inside the room. So one technologist with the cassette will go in the room, one technologist will stay out of the room. And so the only thing becoming contaminated will be the technologist going into the cassette rather than the portable x-ray machine itself. This will reduce the equipment cleaning time, PPE use, as well as potential staff exposures. Any patient transport should also observe droplet or airborne precautions. And this is just an example of obtaining a chest radiograph through the room. This is something we're doing at Hopkins. This is something I know they're doing at University of Washington. And it actually works better than you would imagine. Finally, we'll talk about a little bit of sense of normalcy with changes to our workflows. Really, you should be clustering. Your attendings, your fellows, your residents, your technologists should all be working in a group so that if one member of the group is exposed to COVID-19 or has COVID-19, then that you don't have to quarantine an extended number of healthcare workers. Instead, that team comes offline and the backup team comes online. Social distancing is strongly encouraged of at least 6 feet to reduce potential risk of person-to-person transmission, especially in asymptomatic carriers. If you can, reconfigure your reading rooms and the radiologist in the reading room to maintain social distancing. So if you can touch the radiologist next to you, you're too close. Radiologists should be sterilizing shared workstation equipment before and after use. One reason why after use is you're not sure who's going to be coming in contact with your equipment, and it would be unfortunate that if you were asymptomatic that you were to spread it to another person. If possible, the workstation should be dedicated to a single radiologist for a full shift with cleaning between the shifts. Now, I'm sure this isn't really different from the pre-COVID era, but phone communications between radiologists and their staff are preferable to in-person communications. If you as a radiologist can perform your clinical duties remotely, you should be permitted to do so. If you can create a single radiologist reading room, that should also be done. But I imagine most reading rooms are large and are designed to hold many radiologists, and it wouldn't be feasible to have reading rooms with just one radiologist. If you can, devise workflows for developing virtual consults with ordering clinical teams, and that includes either phone or video conferencing capabilities. And then again, to reiterate, have a standardized reporting system that is developed with agreement of your ordering provider so that you have adequate communication of critical findings and agreement for what those critical findings will be. With regard to social distancing with radiology, the social distancing should be encouraged throughout the department. So that includes in break rooms, congregation areas, the scanner unit, console areas. So these were areas where previously technologists would be really tightly bundled together, but we want to avoid that. We want our technologists to be 6 feet apart as well. If you can, reconfigure the seating in these areas, as well as reduce staffing and stagger their breaks so that not everyone is in the break room at the same time. And this is actually a good point to mention that you should also reconfigure seating in your outpatient settings so that your patients aren't clustered together, because previously the goal was to pack as many patients as you could in a waiting lobby, but that's not going to be the case now or in the short term. So you really want to create social distancing between as many people as you can. Your staff should be educated and engaged and explain the importance of social distancing should be conducted. And if you don't know why social distancing is important, it's the concept of flattening the curve. If too many patients catch COVID-19 at once, the thought is that we will overwhelm the health system and there will be excess mortality from an already pretty devious infection. Meetings should be held via teleconferencing software, such as Zoom, like we're doing now, Cisco's WebEx, Microsoft Teams, or even Skype. Now, if you can have a small meeting with a few attendings and safe social distancing, you can do that as well. Hopkins have opted to do meetings almost entirely through Zoom. Encourage frequent and potentially daily updates to the entire department, as well as within sections and teams, depending on the situation. You don't want your team members or yourself to be out of the loop for an emergent change that happened maybe the evening before. Finally, in terms of keeping engagement and well-being, the radiology leadership should be monitoring for staff anxiety and burnout. These are certainly uncertain times. Everybody is anxious, whether or not they're going to be furloughed or their hours are going to be cut or what's going to happen next. So there's a lot of stress from different dimensions. They should be communicating and engaging with the staff and faculty, and that includes virtual meetings. If you can, have educational new meetings like these ones, just to have some sense of normalcy for your trainees and your faculty. Weekly departmental meetings could be made available to your faculty so that questions and concerns and policy updates could be communicated effectively. And then there's the concept of pregnancy and COVID-19, and there's no evidence yet to indicate teratogenic effects or detrimental effects on pregnancy from COVID-19 infection. But just because we don't know that there aren't any harmful effects doesn't mean we shouldn't be cautious. So we're recommending that if you do have pregnant healthcare workers, that you redeploy them to sites with minimized exposure to COVID-19 patients and patients under investigation, at least until more information is available. Finally, I want to thank you for your patience in this talk. I want to hear about your experiences at your local institutions, as well as ideas that you may have for mitigating healthcare worker spread. You can join us at the COVID-19 RSNA community to share your experiences and other ideas. This is a community for radiologists all across the world. All you need is an RSNA ID to join and participate. And be on the lookout for future work from our task force, including strategies for ramping up imaging once we've sustained a peak and have started to have a decline in positive cases. These are my references. And with that, I'd like to thank you again for your time, and I'll turn it over to the next speaker.
Thank you so much, Dr. Azadi, for that unbelievably informative talk. I'd like to ask Dr. Gill if she could share her screen and we can start the next session. Perfect.
Thank you very much. So for the next 30 minutes, I'm going to be switching gear from COVID-19 and talk about another chest topic, a chest imaging topic. So I'm going to talk about lung cancer, how we see it in our imaging and how we diagnose it, and also talk a little bit about some management strategies. This is the WHO list of the histological subtypes of lung cancer. As you can see that there are many histological subtypes, but we are not going to be talking about each of those. Instead, I'm going to talk about how we see it in imaging and how imaging plays a role in lung cancer. So the first instance, we see a lot of pulmonary nodules, and how do we define what a nodule is and what a mass is by size. When a lesion is less than 3 centimeters, it's referred to as a pulmonary nodule. When lesions are greater than 3 centimeters, they are deemed or referred to as masses, and most of these are always malignant. The incidence of lung cancer the incidence of malignancy among incidentally discovered nodules varies between 10 to 70%. Most of these are found incidentally, and at any one point in time, we are following 150,000 pulmonary nodules annually. These come in all kinds of shapes and sizes. They could be solid, they could be part solid or ground glass. When we encounter a lung nodule, we try and characterize it. And how do we characterize it? We look at the shape, size, density, calcification, doubling times, other information as such. We may have metabolic uptake or enhancement characteristics. The reason we try and characterize it is because we try and do a risk assessment, and the risk assessment will determine if we'll follow this nodule or if this nodule will be resected. Other things that factor into risk assessment include smoking, family histories, and history of prior lung cancer. Here are several nodules which range in size and shape and density, and characterization and qualitative analysis can be very difficult. And a lot of AI and machine learning strategies are currently underway to further help stratify or identify cancers among these nodules. When we look at a nodule, one of the first things we look at is the margin. Is it smooth? Is it lobulated? Is it spiculated? And the reason for that is that when we see spiculated margins, we automatically think that this is a malignant cancer. And not surprisingly, up to 90 to 95% of spiculated lesions tend to be malignant. We also look for calcifications within these lesions, and not just the presence of calcification, but the type of calcification also matters. As you can see that if there is eccentric or speckled areas of calcification within the lesion, that can be seen in malignant lesions, as opposed to diffuse or central and popcorn calcification, which we see in benign nodules. We also look at Hounsfield units or density of the lesion, and there have been several studies which have looked at what the Hounsfield units suggest. And they found that if it was of high density or higher than 264 Hounsfield units, it was always benign. At the same time, if there is fat within a lesion, that may be seen within an hematoma. However, I would caution you to be careful when you look for low density within a lesion, because you can have partial volume averaging through the lung behind it and erroneously think that there is fat or low density within it when you're seeing getting values of the adjacent lung in a mucinous or a low density lesion. Contrast-enhanced CT has been used in certain studies to see if enhancement characteristics could figure out if this was benign or malignant. However, it has not really become a standard of care or has not caught on in other places because of increased risk of radiation exposure and the need for standardization and reproducibility of some of these algorithms. However, Zhang et al. Found that the sensitivity of contrast-enhanced CT may be able to predict that this is a benign or malignant lesion with 95 to 100% sensitivity and a pretty high specificity. MR perfusion, on the other hand, has been used in several studies, including several from Dr. Ono's group in Japan. And this has an advantage over CT because you can image the whole lung or even the nodule over a longer period of time without any radiation risk. And you can plot an enhancement curve, which then can be used to calculate all the pharmacokinetic indices and be used to predict benign versus malignant. However, cost continues to be a factor, and it is so much easier to biopsy than to have 100% sensitivity and specificity with any imaging technique. Talking about MR, diffusion-weighted imaging is in other areas of the body, in lung as well, has been used to characterize or identify histological subtypes of tumors. So if you know the ADC value of a certain tumor, you can predict if it is an adenocarcinoma or a carcinoid or a squamous cell carcinoma. ADC values have also been used to differentiate between well-differentiated and poorly differentiated tumors. Again, more so in the research arena than in clinical practice. Other characteristics of nodules, such as bronchograms, cavitation, pseudocavitation, are also important when we look at lesions, and they have been associated with malignant lesions. Whenever we see a cavity, if it is thick-walled, irregular, then it tends to be more likely to be malignant. Thin-walled, smooth cavities are more often seen in bacterial infections. PET-CT is also used to help identify metabolically active lesions. The biggest advantage of PET-CT is in figuring out any occult metastatic disease outside the chest, which could impact management. Indeterminate pulmonary nodules, when they're less than 3 centimeters, several studies, up to 40 studies with 1,474 pulmonary nodules found that sensitivity of PET was up to 96.8% with a specificity of 78% in predicting malignant tumors. However, remember that lesions less than 8 millimeters will have false negative rates and false positives. Or when we look at PET, when we see inflammation, granulomas, and fungal diseases, especially in areas which are endemic either for the histoplasmosis or tuberculosis areas, we can have a lot of false positives. The specificity of PET-CT has not been well defined in literature. Some people have even alluded to dual point FDG PET when in talking about how to determine benign versus malignant. And so they image at one point and then bring the patient back after a couple of hours or a few hours to see if there is still uptake. And they found that a dual time point PET could help identify benign lesions. However, again, from a practical perspective, this can be very challenging. And, you may not have the scanner be available at the time, or if the patient may not come back at the right time, leading to ambiguous results. Again, to emphasize, resolution of current PET-CTs remains at 8 millimeters. That is also, can be very challenging even at between the 8 and 10 millimeter range as well. Imaging of nodules less than 1 centimeter is unreliable by PET and may provide staging information because up to 14% of stage 1 lung cancers or deemed stage 1 lung cancers on imaging, when we got a PET CT, they may have occult metastatic disease. Again, the pretest probability of malignancy should be what should determine if we want to get a PET CT or not on a patient. So high-risk patients can have a pretest probability of 80%, but they could still have a negative PET in up to 14% cases. So whenever we think the patient has a high risk of malignancy, but the PET CT is negative, it is better to get a tissue diagnosis. When we follow lung nodules using lung cancer screening, we follow the LungRads system to do the recommendations for follow-up. These are patients who have more than 30 pack-year smoking history and are getting a scan because they are at risk for getting lung cancer. So as you will see, the follow-up is based on a LungRads category, and it depends on the size and the characteristics and rate of growth. As an example, a patient with a spiculated lung nodule in a high lots of emphysema, which was PET avid, but was actually a tuberculoma. So remember, detecting small volume change in smaller nodules can be difficult, but it may be much more easier as we get to larger nodules. And again, remember, when we measure nodules, there's an inherent intra-observer variability of 10% built in. I want to kind of put out calculate a probability of malignancy calculator that sometimes we use if lesions are too small to biopsy. We'll put in all the data and see if it is highly likely to be malignant based on all the information put in there. When we have incidental pulmonary nodules incidentally found on chest CTs, we use the Fleischner recommendations, and the Fleischner recommendations are there both for solid and subsolid nodules. Remember, anybody who has a history of prior malignancy, the Fleischner recommendations only apply to patients without any history of prior malignancy. So when we encounter patients with incidental pulmonary nodules with remote histories of malignancy, Fleischner may not apply, and in those category, if you may want to be conservative depending on the size and characteristics of the nodule on the first scan and get a scan in 3 months. And then if the lesion is not growing or is stable, you could go for a longer period of time. Again, calculators are available online. Several calculators are available. This is one that I've used frequently, and so I wanted to kind of make it available for anybody who is interested. And this is on the chestxray.com website. You can calculate the volume doubling times of a nodule. Why do we care about doubling times? Doubling times tell us if lesions what's the rate of growth? Is it exponential? Is it too low? Is it too high? Because depending on what the growth is, you can predict if it is benign or malignant. The thing to remember is that the diameter increased by approximately 26% from the baseline, will equal to a doubling of the volume of the lesion. Average volume doubling times of malignant lesions vary between 20 to 300 days. Radiographic stability has been known to suggest benign processes. However, remember that some of these indolent adenocarcinomas can remain stable and have doubling times in the range of 500 to 700 days, or even up to 10 years in some instances. So that's something you kind of factor other characteristics of the lesion into it as well. Plain film data cannot be applied to screening CT, and CT doubling times can range from 79 to 1,435 days, approximately, for lung cancers. Histological correlates, as I mentioned, patients with indolent adenocarcinomas or Adenocarcinoma in situ or adenocarcinoma spectrum lesions can have doubling times up to 600 days. The squames tend to have doubling times in the 100-120 range. This is several PACS workstations now have inbuilt doubling times built in, and here you can see this is a smooth, well-rounded nodule, which almost was thought to be a granuloma initially, or an intraparenchymal lymph node doubled in 300 days, which is in the malignant range, and it ended up being an adenocarcinoma. At the same time, here's a spiculated lesion with a doubling time, which is much longer, and that's something that you can see in patients with adenocarcinomas. Another thing to talk about when we talk about doubling times is also looking at path solid lesions, and sometimes the actual size of the lesion may not increase, but the solid component increases. And that is why in the current chest recommendations, we always not only measure the size of the whole lesion or the ground glass and the solid component combined, but we also measure the size of the solid component. The reason for that is that the solid component is the part which defines the metastatic potential. And if the solid component increases more than 5 millimeters, up to 1 centimeter, it is still a minimally invasive adenocarcinoma. However, once the size gets bigger than a centimeter, then it can potentially metastasize to lymph nodes. Therefore, it's very important to not only capture the size of the whole lesion, but also the size of the solid component. So why do we go about assessing all these characteristics of lesions? Is because we want to determine a diagnostic strategy. We want to determine what the pretest probability of cancer is in the nodule. And if the pretest probability of cancer is low, we will go about following this lesion till the pretest probability becomes high enough to resect it. In the intermediate range, we do another intervention such as CT or PET-CT or biopsy. When it is high, you may either go for a biopsy or surgery, depending on the risk-benefit ratio of the patient. When the pretest probability is really high, it's almost certain that it's a cancer and nothing else, then the patient may go straight to surgery without a biopsy. However, determining the probability of cancer remains an inexact science, and that is why you see that the algorithms are not followed always consistently as we would see in other cancers. When we talk about resection, another thing that I wanted to kind of like bring it out here is that there are multiple different types of resections that a surgeon may think about, such as lobectomy, bilobectomy, sleeve resection, pneumonectomy, segmentectomy, wedge resection, chest wall resection. A lot of this will depend on how big the lesion is, what it invades, and where how well can they get a negative margin. And it's so, as a radiologist, it's very important for us to describe in detail the actual extent of the lesion. Talking about needle biopsies, the sensitivity ranges between 90 to 93%. Overall, among different studies reported in literature, the sensitivity and the positive predictive value goes higher when lesions are greater than 1 centimeter or greater than 15 millimeters. When you're thinking of benign diagnosis, core biopsies are much more efficient than FNAs. And the incidence of pneumothorax and hemorrhage ranges between 5 to 30% overall. So these are some examples in which you would think about doing a FNA or a core or both. In some instances, the lesion on the top left, you can see that there's a big bleb adjacent to it, and the lesion's right next to the diaphragm. So if you rupture the bleb and get a pneumothorax, you may not see the lesion very well, and so you may not have a chance of getting another diagnosis. So in a lesion like that, if you place your needle correctly and get a core, you may have a better shot. Same thing for the bottom lesion in which it was ground glass. When you do a core or an FNA, you will get hemorrhage and you may not see the lesion very well after that. So it may be easier to just do a core up front. Again, if you're thinking about an FNA, you also need to have on-site cytology or cytotechnologist to assess adequacy of the specimen. In general, 3 FNA passes at least with 22 gauge needles, are required to get enough tissue for diagnostic things. But however, for genomics, you may still need cores. In recent times, because of personalized therapy in lung cancer, more and more cores are needed for profiling lung cancer. And there have been a lot of studies out in literature showing a range of between 83 to 90% adequacy in providing enough tissue for genomic profiling. Again, the pneumothorax rates range between 30 to 50%, depending on which study you're looking at. And the complications were manageable. Again, talking about lung cancer, the other thing that us radiologists are needed to provide is information about staging. And when we talk about staging, there are three components we look at. One is the size, two is the invasion, and the three is the nodal involvement. Nodal involvement is determined by determining the size of the lesion, size of the lymph node. If a lymph node is greater than a centimeter in short axis, it is deemed enlarged. To be on the safe side, greater than 15 millimeters is definitely considered pathologically involved. Sensitivity and specificity of imaging varies when we look at different modalities. For example, CT can miss in chest wall invasion, especially focal chest wall invasion. MR has a higher sensitivity and specificity, and PET-CT is superior to both CT and MR when detecting nodal disease and distant metastasis. Here's an example of mediastinal invasion. The tumor is directly extending into the mediastinum, and this tumor is not only extending into the mediastinum, but the fat planes between the adjacent vessels are also lost. Again, remember that when we are talking about mediastinal invasion, contact between the tumor and the mediastinum, when it extends for more than 3 centimeters because of the mass effect of the mass on the mediastinal fat or the mediastinal pleura, it may be difficult to assess mediastinal invasion. Obliteration of fat plane between the mediastinal and the tumor, again, depending on the size of the tumor, may be poorly delineated and may not definitely mean that it is invaded. So when in doubt, it's always better to kind of have a discussion with the surgeon or try a gated MR to try and see if you can see the fat planes better. Whenever tumor is contacting more than 90 degrees of the aorta, it almost invariably always means that it's invading the aortic wall. However, again, due to the mass effect, the anatomic contiguity may be in doubt. Some people have even explored creating a pneumothorax to see if the mass will fall away from the adjacent structures, depending on how many adhesions are there, or sometimes it may work depending on which location the mass is. Here's a mass which is occluding the left upper lobe bronchus, causing left upper lobe collapse. This patient is resectable and would get a sleeve lobectomy. Here's another example of a central mass. In this case, not only is the mass encasing the aorta for more than 90 degrees, but is also extending into the left atrium, and this is an unresectable tumor. Invasive T3 and T4 tumors, when tumors are any size, but they invade chest wall, diaphragm, mediastinal pleura, or parietal pericardium, or are within 2 centimeters of the carina, or have associated atelectasis or pneumonitis, we upstage the tumors. Same thing for T4 tumors. If they invade the great vessels, or trachea, or esophagus, or any of the vital structures, then they are upstaged. Here's a T3 lesion. This lesion, the size is about 3 centimeters, but the tumor is within 2 centimeters of the carina. So this would be a T3 lesion as opposed to a T2 tumor. Again, remember to always look at the adrenals carefully. Whenever this is a patient with bilateral adrenal metastasis, whenever there are adrenals involved, it is no longer local disease and would go to chemotherapy. Nodal metastasis is common. It can be seen better on PET-CT rather than on CT and MR. Another advantage of PET-CT is that it is very useful in assessing response to therapy. Here you see a complete anatomical and metabolical response to therapy in a patient with stage 4 lung cancer. Switching gears, talking about PANCOAST tumors. These are types of lung cancers which appear in the superior sulcus of the lung or the chest. They were initially described by Dr. PANCOAST in a presidential address to the AMA in 1932. and he described the PANCOAST syndrome, which comprises of a lung cancer involving the apex of the chest, which presents with pain radiating down the arm, Horner syndrome, destruction of adjacent ribs, and atrophy of the hand muscles. So a superior sulcus tumor does not necessarily have to be a lung cancer. It can be a tumor with other histological subtypes and even sometimes is benign etiologies such as infection, presenting with the syndrome described above. So most PANCOAST tumors, why do we talk about these here is that they're a little bit different from a regular lung cancer because they can be locally invasive and still deemed to be resectable. A PANCOAST tumor, it is still deemed resectable if it invades up to 50% of the vertebral body. Absolute contraindications to surgery in terms of invasion include invasion of the brachial plexus, and if the tumor invades more than 50% of the vertebral body or invades the trachea or the esophagus. Here's a very straightforward example of a PANCOAST tumor, and you can see that it has gone in and extended straight into the brachial plexus. The whole brachial plexus is involved by the tumor. This was a nurse who presented with hand weakness and was found to have metastasis from a uterine cancer into the superior sulcus, presenting as a PANCOAST tumor. So this was completely unresectable. In contrast, here's another superior sulcus tumor. You can see that it is clearly sitting in the superior sulcal region, but does not extend into the chest wall and does not invade any of the brachial plexus. This is a resectable tumor. Here's an example of a resectable invasive tumor in the superior sulcus, and you can see that it is invading up less than 50% of the vertebral body and the part of the rib, which is still deemed resectable. So if this patient is resected with negative margins, the 2-year survival can be up to 80%. Talking about multiple nodules, initially people were wary of resecting 2 tumors at the same time, or if you saw nodules in 2 different lobes or different parts of the lungs, they were deemed unresectable, but a lot of pooling data shows that there's a survival benefit to resecting tumors if they are of different histological subtypes, and staged resections are often seen. Here's an example of a patient with a carcinosarcoma in the left upper lobe and an adenocarcinoma in the right upper lobe with multifocal adenocarcinoma seen in the right middle lobe and the lingula. The left-sided tumor was resected with a lobectomy. The GGOs in the left upper lobe were found to be adenocarcinomas in situ. He subsequently went and had a wedge resection of the right upper lobe tumor, and at 5 or 6 years now is still disease-free. We talked about the adrenals. Again, remember that 2 to 10% of the general population will have adenomas. When in doubt, either do a biopsy or an MR to further assess the histological subtype, histological involvement of the tumor within the adrenals. We as radiologists also are involved with response assessment. The criteria that we normally use are the RECIST criteria, which are based on target lesions and non-target lesions. Target lesions are quantitatively assessed and non-target lesions are qualitatively assessed. Here's an example on how we assess response in different types of therapies. We will pick target lesions, approximately 5 lesions per organ, 5 lesions in total, 2 per organ. We pick lesions which will be reproducibly measured over a period of time, and other lesions which are non-reproducible or do not satisfy the criteria of target lesions may be counted as non-target lesions. In general, brain lesions, bone lesions, lymphangitic carcinomatosis, and previously treated lesions are better chosen as non-target lesions. You measure the lymph nodes in the short axis, and then they're followed over time. We use RECIST 1.1 for chemotherapy, and when the lesion increases or the total sum of lesions increases from baseline, we call it progression, and we stop treatment at that time. In immune response in immune therapy, immune response criteria are used, in which a single time point beyond progression is allowed to account for pseudoprogression. When treating patients with targeted therapy, you will see that a lot of these patients are nowadays allowed to continue on targeted therapy even beyond progression. The first step generally is assessing the overall disease distribution of the tumor. Would involve a CT or an MR of the head along with a bone scan or a PET CT and identifying 2 lesions per organ, a total of 5 which are reproducible and representative of the disease. Here's an example on how you would assess response to chemotherapy, and you follow the patient till the disease progresses, and then is the patient's deemed progressive disease and stop there. In immune therapy, you continue to follow one time point beyond progression. In immune therapy, you may see complete response as well. When looking at targeted therapies, there are 3 types of progression that are normally seen. In patients who have gradual progression or local progression, patients are allowed to progress over time and still continued on the therapy. Some of these patients can have very dramatic response, but the tumor may come back after 24 to 36 months. Evaluation of response can happen very early, and we may see response as early as 14 days. PET CT can also be used to assess response, and there are 2 types of criteria that are used based on basically how SUV is assessed. One is the PERSIST and one is the URTC criteria. Timing of the PET CT is very important, and if you scan somebody too early, for example, here a patient of post-ablation was scanned in 3.5 weeks, you can make an error in assessing response. Again, other tracers are being made available, such as FLT, which is very useful to assess for proliferation and can determine tumor within previously radiated sites. We also see a lot of adverse events when we assess response, and I would recommend you refer to pneumotox.com. It is an updated website which lists all the different types of response adverse events related to different drugs. To summarize, here's an example of a patient with stage 1 esophageal and stage 4 lung cancer. So always remember, smoking can cause other tumors as well. Be careful of pleural effusions. This is a patient with T4 because there's another nodule in the left lower lobe. Right supraclavicular lymph node, which is an N3 node. With that, thank you very much. Please send me your questions and I will answer them as I come by. Thank you.